All right, so I think we'll go ahead and get started today. I first just want to thank everyone who was able to join us for session 1 last week, and this is session 2. And today we're going to be focusing on using data to bring hard to reach women in for care. So just a few housekeeping items. So this is set up as a webinar, so attendees are automatically muted, but please be prepared to share. We have a few polling questions, and it would be really great to learn a little bit more about, what you guys are doing out in the field. Feel free at any time to put your questions in chat, and the session will be recorded, and we will kind of send everyone the slides and recording when we're done with the session. So today's agenda, we're going to overview patient visit types, protocols, and data to identify new opportunities for women to receive timely care, discuss designing workflows to flag patients needing preventative health visits, and examining examples of using practice level data to seek out patients for care. We definitely won't take up all of your hour of time today. We're just really wanting to get very technical and, maybe a few things that you could take back to your practice and implement today. So today's presenters is myself, Erin Ackelstead. I'm with Mountain Pacific Quality Health, and I primarily focus on working with the state to increase preventative cancer screenings. And we also have Jeff Redekop, who is joining us from Quality Health Associates of North Dakota, and he is a quality improvement specialist. So thank you so much, Jeff, for joining. And I'm actually going to turn it over to Jeff.
Thanks, Erin. So we're going to start out today looking at a few key factors from 2019 statewide data in Alaska to consider when you're looking at your patient population of women who aren't receiving regular well woman visits and cervical cancer screenings. So think about what this looks like at your clinic and how some of these factors could potentially be impacting the patients who most need preventative services. Erin, what were you hearing at the Alaska Cancer Partnership meeting in terms of some data that you were thinking about sharing?
Yeah, so I was able to attend the Alaska Partnership, the Alaska Cancer Partnership meeting last Friday, and they shared a lot of really great, valuable data. I think in terms of not the health equity piece, but adherence to cancer screening guidelines, just for some information in case you weren't able to attend that meeting. They provided some statewide data, so adherence to cancer screening. So for cervical cancer screening, at the year end of March 2022, they were seeing about 74.9% adherence to cervical cancer screenings. And so when we looked at comparison, or when they looked at this data is from the Ladies First program. So when they looked at 2021 data compared to 2022 data, some of the areas that actually saw a slight decrease was Anchorage, the Gulf Coast, and the Mat-Su-Borough areas saw a decrease in cervical cancer screenings. The more notable decrease was in the Anchorage area. And then for breast cancer screening, it was actually at adherence of 81%. And there wasn't as many areas that saw a decrease in screenings, which is great. So the areas that did see a decrease in adherence to breast cancer screenings was the Gulf Coast and the Mat-Su-Borough. So thinking about those data points, so the 74%, the 81%, Alaska overall, and I think we talked about this last time, is doing really great with regards to preventative cancer screenings. But of course, there's always areas of improvement, and there's always populations that we may not be reaching. So this is kind of what we're talking about today, is like, how do we reach those women who aren't coming in for screenings, and how do we identify them? How do we identify the gaps in care? And yeah, that's really what we're hoping to talk about today. And then I also think from an equity standpoint is, looking at your patient populations and thinking about, who are you serving in your communities, and, breaking down your data from there. So that's kind of a great segue into what we're going to talk about today. So Jeff, I'll turn it back over to you.
Thanks, Erin, and thanks for sharing those numbers. And they really are going to tie in with this next slide here, because here we're breaking down different regions of the state. So you've got some social determinants of health here to be thinking about with your patients who aren't making it into your clinic on a regular basis for those preventative services. And one thing that sometimes gets overlooked, I'm going to mention here, is women with disabilities are screened for cervical cancer far less frequently than women without disabilities. And women with severe physical disabilities may be even less likely to receive preventative health screenings than women with less severe disabilities. Providers may have a misguided attitude and assumption regarding sexuality in women with disabilities, which could also cause them to be less likely to be screened. Think about the region of your state that your clinic is located in, and how could the factors listed on our table here be impacting your attendance rates? At many clinics, most appointment types can really be broken down into the 3 different categories that we see here on the screen: routine care, non-urgent follow-up visits, and urgent visits. Routine care can encompass establishing care, consultation, or any other type of regular periodic visit. And with your non-urgent visits, follow-up, that's looking like test results being reviewed, or any other type of monitoring, or various chronic medical conditions, as well as any type of post-ED or hospital discharge follow-up. Urgent visits can cover any kind of a new diagnosis or new onset medical condition, especially if the patient believes that they need to be assessed and it's possible to avoid going to the ED as a result. So evaluating the visit types your clinic offers is a good first step in identifying subpopulations of patients who are either returning or not returning for their well women visits and cervical cancer screenings. What percentage of your patients are coming in for only certain types of routine care? How many of your patients are using your clinic as an urgent care center only to cover episodic needs so they can avoid having to go to the ED? Here's something to keep in mind as well, too, about the various visit types. The Institute of Health for Healthcare Improvement recommends not having separate appointment types for urgent visits versus routine needs. And the reason for this is that they state that the only distinction between appointment types that are really needed are provider is present versus provider absent, short appointment type for return visits, and a long appointment type for physicals and for new patients. The reasoning that they have is that reducing the appointment types will simplify the telephone appointment triage, and it gives the patients more flexibility and reduces the queues in the phone system. And as we talked about in our previous session, appointment access can be a big barrier for patients who are needing a well woman visit or cervical cancer screening. Here's some other influences that could be affecting those women who aren't attending well woman visits and or cervical cancer screenings. Cost of care and timely access play a big role for these services, and not being able to have a provider who understands a patient's cultural norms, values, expectations, or their communication style can inhibit women from seeking any type of regular care, not just preventative. And not having access to a female provider can also be a detriment for some women. It's very likely that you have patients who use your clinic for urgent, episodic care, as well as we mentioned earlier. And these are the people that you want to reach out to first to find out their willingness to commit to a well woman visit and or a cervical cancer screening. Find out from them upfront if they're receiving regular care at any other primary care clinic, because it is possible that they may only be using your clinic as a backup when they can't get into their home clinic. The next group will be those who are new to your clinic to establish care. And if these two services were not discussed or scheduled at the time of their initial visit, it's wise to contact these folks as soon as possible so that those appointments can get scheduled. One other point to consider here is several studies have shown that when patients are scheduled for the next appointment prior to leaving their current appointment, regardless of what that future appointment is, they have a substantially increased attendance rates at that future appointment. So keep that in mind. Think about how you can use statewide data registries, such as the immunization registry, to also identify patients who are missing HPV and HBV vaccinations. Every clinic needs some type of a functional and accurate system to be able to track when patients need care. A reliable tracking system can be manual or electronic. Your system can be in the form of a logbook, card files, file folders, or a computer system, or basically any method accessible for ongoing updates and monitoring. Computerized systems can be helpful, but they can also be very complex and may be expensive and time-consuming. As more practices incorporate EHRs, the use of computer-driven tracking and reminder systems will become a lot more common. In many EHR systems, healthcare providers can receive notifications that flag them when preventative screening tests are due or overdue, and many systems also will search the results of previously ordered tests. If your clinic does have an EHR and you haven't been able to use any kind of a tracking system associated with it, talk to your vendor and find out what customizations are available that they can set up to meet your needs for being able to flag those patients who are due or overdue for these services. Establish a policy to periodically run clinical data reports that track performance and ensure 100% of your patient population has the appropriate preventative services and screenings assigned in the EHR. In practices without an EHR system, a simple paper-based tickler system can be developed. And no matter which system you use at your particular location, data entry should be prompt and correct. So our first polling question here, we'd really like to hear about what you're doing at your clinic currently. So what method does your clinic use to determine when a patient is due for a well-woman visit or cervical cancer screening? So please go ahead and take the next minute or so and go ahead and answer what you all are doing at your location. Okay, so it looks like we've got a few EHR reminders and some quality reports. Erin, have you heard anything from those clinics that you're working with as far as what they're doing?
I think, kind of what's being reflected is just using those EHR reminders, using quality reporting. I know some folks that we've worked with, they've kind of gone away from using their EHR to actually conduct not necessarily the reminders, but figuring out who's due to tell them, that they're due for a woman visit or a cervical cancer screening. So it's just kind of a little bit all over the board where they're at and their familiarity with their EHR and utilizing the quality reports. But it looks like the folks on our call today are, kind of going about it in that direction. So that's great.
Yeah, thanks for sharing that, Erin. Well, let's take a look at our results. Okay, it looks like we've got pretty even spread here between EHR reminders and quality reports. So we can go ahead and close out that poll, please. There we go. Embedding clinical functions like empanelment, risk stratification, social determinants of health screenings, and using a team-based care approach can help develop additional processes and workflows that can make it a lot simpler to identify patient populations that you want to target with these visits. Today, we're only going to discuss these briefly because we currently have another series that's in development called Practice Transformation that's going to cover these concepts in more detail, as well as discussing advanced care management in greater depth. And we encourage you to attend those as soon as they're available. If you have more than one provider at your practice, the single most important step that you can take to build relationships with your patients based on mutual communication and trust is empanelment. And empanelment is going to help accomplish this goal because it uses a series of steps to connect each patient in your clinic with a provider and or care team. This way, every single patient is going to have a provider or care team that's consistently responsible for overseeing their needs. Empanelment puts the patient in position to receive the right care at the right time from somebody they know and have faith and confidence in, which can help improve appointment attendance, especially for those individuals that are due for the services that we're talking about today. Empanelment supports continuity of care and fosters a controlled healthcare environment that allows practices to be able to lay the groundwork for addressing preventative needs on a timely basis, and also helps the care team hone in on a defined group of patients. Empanelment can improve patient health outcomes by ensuring responsibility for a group of patients, regardless of if they seek care, rather than reactively treating those patients who access health services. Regular visits with the same provider positively affect patient experience, clinical care, and patient outcomes. Empanelment also helps the provider and the care team customize care delivery based on the individual's needs and can bring in a sense of order and efficiency into the daily schedule. The process also helps each provider and care team better coordinate care across different providers and levels of care. Risk stratification is a process of assigning a risk level to all of your patients. This process helps practices develop strategies to be able to address the needs of high and rising risk patients while also assessing and providing routine and preventative care for those patients that fall into the medium and low risk category. Risk stratification gives the provider and care team a more accurate perspective of what actions need to be taken to meet the needs of your total patient population. This way, you can pinpoint those individuals requiring more care, such as those people needing well woman visits or cervical cancer screenings, and be able to allocate those resources accordingly. Risk statuses are based on data that reflects vital health indicators, lifestyle, and medical history. And the overall goal of risk stratification is to be able to identify those patients who are most likely to benefit from defined levels of care to improve patient outcomes and decrease costs. The best health risk stratification leads to meaningful action steps to catch potential problems before they occur. Risk stratification also gives a team and the provider a starting point of how to effectively manage each patient in their panel and be able to make sure that their work is targeted and efficient. The systematic approach also helps to provide whole person care for your entire patient population. Just remember that you can't address what you don't assess. So risk stratification helps uncover those risks and stratify those needs. One of the benefits of risk stratification is that it can help your practice improve health equity. Risk stratification can provide a better way to target those patients with disparities so that they can be in a position to have greater access to timely care and have those preventative visits and screenings to be able to catch those problems before they start. You want to keep in mind that each patient's risk level will change with age and changes in their health status. It's going to be important for you to discuss with your team how often you feel is reasonable to be assessing risk for your patient population, and then determine how to flag that step so it gets completed on a regular basis. Many practices have used claims data, diagnoses, and also clinical data to be able to establish these different risk levels. And there are a lot of different EHR vendors that provide analytics software and algorithm customization to be able to meet your practice's needs. Most health outcomes are related to much more to social, environmental, and economic factors than to clinical interventions. Social determinants of health also contribute to wide health disparities and inequities. For example, people who don't have access to grocery stores with healthy foods are a lot less likely to have good nutrition. That raises their risk of health conditions like heart disease, diabetes, and cancer, and even lowers life expectancy relative to people who do have access to these healthy foods. Many patients may not volunteer that they're experiencing these challenges during a brief interaction with a care team or a practitioner. Ensure your patients get the right care at the right time by making sure that your practice is asking the right questions in a way that elicits candid responses and is going to allow you to learn the prevalence and impact of the unmet health-related social needs in your population that may be affecting your lady's ability to come in and attend those well woman visits and get those cervical cancer screenings on time. Your team may find that most of those women who are missing those important visits rule in for one or more of these social determinant of health categories that are keeping them from coming in for those preventative care services. And the results of the screening for the social determinants of health can provide you with valuable data that can potentially uncover disparities in your patient population that you were previously unaware of, and help your team be able to strategize how to act or refer for urgent and high value needs that emerge as a result of these screening processes. And one thing I'll mention here is American Association of Family Practice has a nice website where they talk about social determinants of health screenings, and they do have some nice tools available too that are for free. Team-based care is a collaborative system that allows team members to share responsibilities to achieve high quality and efficient patient care. By clearly defining the roles and responsibilities of care team members, fostering effective communication, and establishing protocols and support tools, long-standing challenges can be overcome. A team-based approach can provide proactive and timely access to appropriate preventative care, which can ultimately improve outcomes of the patients. Team-based care ensures multiple perspectives that will help close gaps in the patient care. Multiple roles working together also make fewer mistakes, which leads to better overall care for the patient, and can also help reduce missed opportunities to provide these preventative services. With clinical and non-clinical staff working together as a team, it's vital to define and communicate responsibilities and roles to ensure that streamlined and well-coordinated care occurs. There are several tools and processes built into the way team-based care is conducted to help ensure needed preventative services are provided in a timely manner. Pre-visit planning helps the team get ready for the patient before they attend the appointment and can help identify any screenings that are due or overdue. Team huddles can help your team be able to complete pre-visit prep work to identify those care gaps and social needs. When the team uses protocols and standing orders, patients' care can be shared among the members, especially those tasks and duties that have been previously performed by the provider, but can be delegated to another individual. So for our second polling question here today, we'd like to find out what electronic health record data are you currently using to identify your gaps in care? And again, please go ahead and take about the next minute or so to go ahead and share your responses. One of the things that I've heard here from practices in North Dakota that I've worked with over the last 2 or 3 years is that a lot of them are using panel reports. We have a lot of Epic users here in the state as far as their EHR vendor, and they've been able to work with Epic to be able to customize a lot of those reports so they can pull those and be able to determine which patients need what preventative services at what time. So it looks like we've kind of got a mix here of quality measure reporting and manual practice reports. We'll give people another minute or so to be able to, or a few more seconds to share any other answers they want to have. One of the other pieces of TeamBased Care that I've encountered within practices here in North Dakota as well is some of the practices have actual panel specialists, which are able to run these panel reports to be able to figure out which patients are due for which preventative services, and especially with system-based practices, that's becoming much more common to have those positions in place working with the practices. All right, so let's take a look at our results. And it looks like we've got most people are using quality reporting, and one practice has got some customized reports, great, and then some manual practice reports as well. All right, thank you everybody for sharing. So if your practice participates in any type of a clinical quality measure reporting and payment program, like for example, MIPS, you can use your performance data as a means to identify patients needing cervical cancer screening by looking at those patients who fall out of the numerator. And as we've saw for the 2 polling questions, some of you are already using your quality reporting. It's also possible that these patients who do fall out of the numerator may be due or overdue for a well wound visit. So additionally, for those same participating practices, you may want to take a look at your data for CMS 122, which is your diabetes, hemoglobin A1C, poor control, hemoglobin A1C levels greater than 9%, and or CMS 165, which is your high blood pressure control, a quality measure for those patients that do fall out of the numerator. Because if they do fall out on either one of those 2, as a result of inconsistent appointment attendance, then it could mean that they're also missing those opportunities to receive preventative services like we're talking about today. So as far as practice-specific data to access other than quality measures, we can look at lab results as well, because sometimes receiving timely cervical cancer screening results from the lab can really be a challenge for some practices. Delayed results lead to delayed communication, which can lead to delayed treatment if screening reveals that positive test. Having an automated system embedded in your EHR can help track and follow up on those delays and eliminate unnecessary time lapses, which is going to allow you to determine which patients may be falling into this care gap. So if you don't have any type of a system set up already to be able to allow this, reach out to your EHR vendor and work with them to develop an automatic results delivery connection system between the lab and the EHR, and create a method of identifying which patients are missing lab results within the time frame that those lab results should be delivered. Demographics are also another key practice level data source that you can access to get a better idea of your patient population that are not receiving those timely well woman visits and those cervical cancer screenings. Knowing the demographics of the population, missing appointments are also going to help you target your outreach efforts, as well as help you identify which patients to have specific discussions with when they do attend those face-to-face appointments, and be able to develop a strategy from those discussions. If you have an EHR system, work with your vendor to develop automated reports that you can run to evaluate these different factors. We're going to take a look at these 4 categories as well as a few other demographic sets as well. And this data that we're going to be looking at is a little bit delayed the set that we have access to is from 2014 to 2018. So for this series that we're doing here, the group we're most closely looking at is ages of women 18 to 44. As we mentioned in the previous session, women aged 18 to 24 had the highest well woman attendance rates, while women aged 25 to 34 had the highest cervical cancer screening rates. Women aged 35 to 44 had the lowest well woman attendance rates. So you could begin with reviewing that population for missed opportunities there. Likewise, there's no cervical cancer screening data available for women who are aged 18 to 24, which could indicate some gaps there as well. Again, the most recent statewide data we have access to is 2014 to 2018. And in those sets, white women had the lowest rates of both well woman visits and cervical cancer screening rates, than much lower than Alaska Native or multiracial women. So in your particular area and location, this may not necessarily be the case. So it's a good idea to take a look at your individual practice panels and be able to develop reports to see what groups would benefit from outreach and focused conversations. Cost is a critical component of the ability for women to be able to seek care and receive that preventative care. Patient populations with limited or no insurance seeking care have to make hard choices about what to spend limited funds on. Patients with Medicaid can encounter restrictions regarding the extent of services that are covered. Although there isn't statewide aggregated data available for this category, we do have data broken down by income level, which can often dictate the presence or lack of insurance coverage. Women with the lowest income levels at $25,000 per year or less have the lowest rates of attending well woman visits. Areas of the state designated as frontier regions can have challenges on two fronts. Travel distance for patients can hamper attendance rates, particularly given seasonal weather changes. These areas often experience difficulty securing and retraining and retaining well-trained women's health providers, which leads to a shortage of available appointment dates and times. So take a look at your patient populations with travel times of greater than 30 minutes in duration one way, and develop a plan to designate some appointment times and dates for them that are going to offer more convenience and better access. And also then for those same population groups, take the time of year into account as well. Here are some other factors that you may want to consider within your respective patient populations. Having a social and emotional support system is important for all of us, and women living alone and those who are single may have less support than those who live with another person or who are married. The support and encouragement of someone from a close relationship, especially if that person has good health literacy and is a strong influence, can sometimes make the difference in choosing to seek care for preventative services versus deciding they aren't necessary. A woman who has recently given birth to a child may be too emotionally overwhelmed or physically tired to seek care, as well as possibly feeling that her new baby, along with others in her family, take priority over her taking care of her health. Language can be a significant barrier for women who have English as a second language or speak no English. And before we move into talking about revenue, here's one other thing to think about. Payers compile a great deal of beneficiary data. Consider forming a partnership to identify patients who fall within your target population that haven't had a well woman visit or cervical cancer screening within the next recommended time frame. Now I'm going to pass it back over to Erin, who is going to talk about some reimbursement and revenue information.
Yeah, thank you, Jeff. So I'm going to be talking a little bit about maximizing your billing and coding for well women visits. Because of course you want to get reimbursed for all the great work that you guys are doing at your practices. So getting the full reimbursement for and using the correct codes for preventative services like well women visits can be a challenge. Same with cervical cancer screening specifically. Because coverage rules can vary between payers, which I think we all know. So for example, Medicaid doesn't cover preventative cancer screening. So how are you really serving that population is one thing to think about. You know, the Ladies First program does provide financial support for women on Medicaid to receive a breast cancer screening and a cervical cancer screening. So when you think about sending reminders to, you know, if you're sending it out to all of those patients who are due for cervical or breast cancer screenings while they're coming in for a well women visit, maybe the messaging should be a little bit more targeted. So that thought is a little bit away from, you know, maximizing our billing and coding, but that's a patient population that has insurance, but they don't have the coverage. So really being familiar with what the payers are covering and what they're not covering is really important. And also making sure that the EHR is set up how it is intended to be used. So the information on the slide provides a step-by-step guide of how to get the most reimbursement for the service your practice is providing. We're going to talk about kind of like the range of codes on the next slide a little bit more. But so providing kind of the ABN for Medicare annual physician exam, the codes for preventative medicine services, checking the preventative service documentation, reserving the CPT mammogram code. So, and really just ensuring that your EHR is set up to bill and code correctly. And then training your staff, training to overcome those coding challenges for combined visits, and really just understanding, I think, what is covered by the different insurance companies is really important to providing the best care for your patients as well. And knowing what, I know it can be overwhelming, and we've talked about this in a couple of meetings previously, is if a patient comes in, you know, they may not understand the coverage that they have. So that's just another way of, you know, maybe helping, you know, having staff able to help them kind of understand their coverage and understand what they're there, you know, what the visit is actually entailing and those types of activities. So next slide. So a little bit more about billing and coding. So most, like we just said, kind of most US commercial health insurance plans pay for annual screenings, which is great and so helpful. But again, I just like to hone in on kind of like that Medicaid population, because so if a patient has Medicaid, but they only have coverage, let's say, for example, from Ladies First, they may just be presenting solely for a cervical cancer screenings and may not be there for the full women's wellness visit. As much as we want to capitalize on them being at that office visit and wanting to run, you know, all the tests and everything that, you know, we should be doing, or, you know, providers should be doing, you know, to ensure that the patient is well in general and checking all of their labs and everything, they may just be presenting for a cervical cancer screening. But wellness visits, they're always an opportunity to have any sort of preventative cancer screening like cervical cancer screening. And any test, screening, or procedure, it's always wise to verify the accuracy and compliance of all billing and coding practices of services being delivered, that they meet the screening criteria to ensure proper payment. Because again, your patients may not really understand what is covered. And I would probably, this is just an assumption that, you know, a lot of patients don't know exactly what is covered by their insurance, because it is an extremely lengthy document that you get. And I think we all know that from the insurance coverage that, you know, many of us are thankful to have. But again, I think this also comes back to the health literacy piece on, you know, the grade level for health literacy information that is provided to patients should be at the third grade reading level. And do we think a lot of the information that the patient is getting on insurance is at the third grade rating level to kind of be easy to understand, that may not be the case. And then obviously just checking the most recent guides for up-to-date instructions. So ensuring that you have the most up-to-date, codes and that your EHR is set up correctly. And then up above here on the slide, so if using CPT preventative medicine services, you can look at those codes 99381 to 99397 for a series. And then using E&M codes for a symptom or condition, and practitioner also obtains a pap smear report, only the E&M service. So there's lots of information out there on billing and coding, but I think it's really, when we're looking at health equity and looking at those more disparate populations is, do they really understand what is being covered? And do we, as, in the practice or, front office staff or any support staff you may have, do they understand and are they able to help communicate with the patient? Like what are they coming in for? What can be covered? Because the expectation may be that they should know exactly what is being covered by their insurance may not be the case. So I think that's just what I wanted to note on billing and coding, even though we're always trying to also look at the financial side, and that, return on maximizing your billing and coding is also looking at that, that other piece as well. So next slide. So this is really our last polling question. So would you be interested in working on a quality improvement project to improve health outcomes for Alaska women? So I know that we talked a lot about at a very high level, basic things that you can do in your practice, and things that we may already know, like, empanelment and reminders, but do you really take the time to kind of implement these things and make the time? So through the state of Alaska, DHSS, they have multiple opportunities for you to receive technical assistance that's of no cost to your practice. So you could possibly, and it's really meeting you where you're at. So either looking at your data, looking at gaps in care, identifying, those target populations that maybe you're not reaching in your community, looking at your education material. Are you wanting in your community, do you have a particular population that you want to do reminders with? And, should you look at tailoring some education material? That also can come down to the material that is canned coming out of the EHR is not necessarily always at a low reading level that would be accessible and readable by everyone. So that's another area that could be looked at. Also, just looking basically at your preventative cancer screenings. Are you wanting to increase those preventative cancer screenings at your practice? Did COVID have an impact on getting women into care, to getting into those annual wellness visits, or coming in for those cervical cancer screenings or breast cancer screenings? So if those are things that you're wanting to look at, some dedicated time, there is technical assistance and support and resources available to you. So I think we'll just give it another minute if you don't mind kind of noting on the poll if you would be interested in that. And we'll just give it one more second. And I just want to note, I know that a lot of clinics are not reporting to MIPS, or primary care practices aren't reporting to MIPS or, any other quality reporting program now, but it's always good to kind of look at your data or learn how to utilize your data to kind of best serve your patients, and making sure it's set up correctly, making sure, that you can identify gaps in care, and an EHR is a great tool to be able to do that. So great, I think we can close the poll and go to our next slide. Thank you. Yeah, so we can go to the next slide, Jeff. I don't think we need to, thank you. All right. Yeah, so we'll be following up with you if you noted that you would be interested in technical assistance. So we really appreciate your time. I know that we had a question kind of on learning a little bit more about some of the resources from the first slide. So we'll get those sent out. And yeah, so if anyone has any additional questions or comments, that would be great. This is the right time. But I think that was all that we really wanted to provide you guys today. And we hope you at least, have some ideas to take back to your practice, whether you want technical assistance or not, or if you want some support working on any of these areas. That's great. And we just hope you have some takeaways today to kind of maybe look around in your data a little bit more. So Jeff, any final thoughts, or if you have any questions, please feel free to put them in the chat.
And like Erin mentioned, one of our final slides is going to have some resources available for you. So you'll be able to find out where we pulled our information from, and you'll be able to follow up on any types of things that you have further interest or want to get a little bit more content on. So again, if you do have any questions, please go ahead and we'll give you another minute or so to share those, and then we'll close out.
All right. Well, thank you everyone so much for joining, and we will make sure that we get the slides sent out along with the recordings as soon as they turn into the YouTube links, and we'll have them available for everyone. Again, we appreciate your time, and we hope you have some takeaways from today's session. Thank you so much.
Have a good rest of your day, everyone.